Welcome, everyone. My name is Madi Partovi, Dr. Ryan's wife and practice manager. We are co-owners of Aspen Wellness Institute, and our overarching commitment to the planet and to the people is optimum wellness. Inside of that, today's event is with an intention to be of service to you, to answer any health and wellness questions that are there for you, COVID related or not. And I'd like to welcome you today. Thank you for your presence. Thank you for being here. Thank you for being part of our community that is just you're all over the world, really. And I feel that we have a relationship with you that is enduring, and especially in these times of uncertainty. So you can count on us to be here for you for either active COVID treatment, anything COVID related, anything that's health and wellness related. That's really what one of my friends asked me, what my passion was in our business. We have COVID related offerings, we have the health and wellness plan, we have fertility. And I was just really being with it, and health and wellness, like fundamental and optimal health and wellness, and educating people and opening their entire worlds to something completely new. And we've been able to achieve so much through the annual wellness plan. And I really look forward to announcing some new developments and new offerings for you today. So the way that we're going to start is a little bit different than we anticipated. We'll start right away with your health and wellness questions. And there are already some rolling in through the chat. So please feel free to you can raise your hand, and ask them directly. Feel free to type them in the chat to the group, or if you'd like to remain anonymous with your question, you can message me directly. Okay, I'd like to introduce you to Dr. Ryan and to Anna. First, a few words about Anna. I think you all know she's our office manager. She's really what has things work so beautifully, and so the way that she's connected to our community is so powerful and with speed. And I am grateful to have her on the team and to have her represent today. Anna, can you say hi so people know? And then Dr. Ryan, who has been from the very beginning, just steadfast, a person of integrity and honor and courage in the way that he has wielded his expertise as a doctor. So let's open the floor to questions. And I've had a few rolling in, Dr. Ryan, so Pam wrote the group. Hi, Pam. So is Ivermectin still necessary for a mild case of the new variant?
Great question. The thing to keep in mind before I just go straight to the answer is why the answer is the way the answer is. Just to take you back to that study that came out of the Salk Institute fairly early on in the pandemic that showed that the spike protein of the virus, whether it be from the vaccine or from the virus, is the mechanism by which COVID, the SARS-CoV-2 virus, exerts its cardiotoxicity. We found that cardiotoxicity seems to be a little more of a problem just in the intervening sort of 3 years. We found that the cardiotoxicity seems to be more of an issue with men. I have a hypothesis to why that is, but I find more neurological consequences in women. And that's not just me. I mean, there's been a lot of doctors who reported that was reported at the EFLCCC conference a few months ago, that other doctors are saying the same thing. And there's evidence that long COVID tends to also sort of fall out in that same pattern where you see men will tend to have more likelihood. It's not absolute, right? But I think it's because of the way testosterone helps the virus get into the cells. We now know that's the reason why men were dying more readily. And so I think that because it's sort of helping the virus get into the cells, it sort of helps with cardiac tissue is generally a little more protected, but in the case of COVID, it seems like it does get into the bloodstream. It is able to get into that cardiac tissue first if there's that testosterone to help it. And then without as much testosterone, it has more time to work its way into the nervous system. That's my hypothesis. I I literally made that up, but it makes sense to me. Just in terms of basic biology, it seems plausible as an explanation, because we know that there's a receptor on the surface of pretty much all of our cells, almost all of our cells, that where the testosterone will bind and it can help the virus get into the cells. It facilitates ACE2 receptor binding. Given that, there's really no safe dose of spike protein. It's not, oh, I'm just getting a little bit of exposure to spike protein. It's like radiation. I think about it like radiation. My radiology professor used to say, there's no safe dose of radiation. You may get exposed to a low enough dose that doesn't cause you any immediate problems, but over time, the effect of X-ray here, X-ray there, eventually you may end up getting cancer. So you really want to minimize X-rays. CT scans are 200 X-rays each. So I only order those on patients if it's literally the only option, because usually we can do an MRI and that'll work better. There's a couple of circumstances where you really need to do a CT, specifically if you get in an accident, car accident or other traumatic accident, and you hit your head, and there's a concern that maybe you might have an internal bleed. You don't have time for an MRI. Anyway, I don't want to get down a rabbit hole with MRIs versus CTs, but I will just say the analogy of radiation exposure and spike protein exposure is actually pretty good, because we do know that spike protein exposure actually has some of the same effects, and not just in terms of cardiotoxicity and neurological toxicity, but also increases risk of diabetes, increases the risk of certain cancers. We've seen recurrence of cancers in people who were in remission after they got a vaccine or if they got COVID. So there does seem to be a very systemic effect. We've seen spike protein deposited pretty much, and this has been documented by Dr. Ryan Cole, pretty much throughout the body in different pathological samples. Because spike protein has the cytotoxic, literally just meaning toxic to your cells, right? Like damaging, poisonous to your body effects, any exposure is too much. And so really the best prevention, the best treatment is prevention. And I don't, with regard to ivermectin prevention specifically, we really recommend that in people who've never had COVID, in people who have had long COVID or still struggle with symptoms of long COVID, in people who have had COVID, they've recovered, but they still have 2 or more comorbidities, or they're just constantly they work on the COVID floor of the local hospital. So that's the group that we would recommend beyond preventive ivermectin, especially during the sort of COVID season, which we're, in the midst of now. It's begun. But in terms of the general population, do people who've had COVID before, they have maybe 1 or 0 or 1 comorbidities, they recovered fine from the first round, they didn't have long COVID, do they need to be on preventive ivermectin? I would say no. But for those patients, we would recommend they get the COVID PrEP package, which basically is the 4 core medications of the FLCCC protocol that we use in our practice, which is ivermectin, hydroxychloroquine, calcitriol, which is the active form of vitamin D. It's the form that D3 gets converted into, and then fluvoxamine. Fluvoxamine, really, because COVID is able to cross the blood-brain barrier, ivermectin is not. So we need a medication that's able to get into the nervous system. I find it's especially important in women, but I prescribe it to all my patients. And I really am a big fan of I've been doing fluvoxamine from the beginning. I think a lot of the bad press that fluvoxamine gets in FLCCC circles comes from the fact that people don't give the right instructions on how to take it, which is you have to take the first dose at bedtime. Because if you take the first dose in the morning, it's going to make you feel pretty badly, because your body needs to be horizontal while it's adapting to that medication. But we find that if people do take the first dose at bedtime, 90% of people tolerate it without any side effects, and then whatever other side effects may be, very manageable. So we still use it. It's part of the core 4 medications, and we really recommend taking the protocol as a protocol because it really works. Since we started using that protocol, anybody who's been treated early, and I would say even within the first 5 days of treatment, or of symptoms rather, has not gone on to develop long haul COVID syndrome or pneumonia or anything like that. I would say that in the realm of spike protein and spike protein damage, talking about long COVID, the estimates vary anywhere from 33% all the way up to maybe 80% of people who have symptoms of long COVID. It really depends on where you put the cutoff. If you say it's 1 month, 3 months, 6 months, you're going to get a different percentage. So I would say that probably that 80% number comes from people looking at it 1 month after the fact. Do they still have fatigue? Do they still have some shortness of breath on exertion? Probably there is a significant portion of people that do. And then I would say the 33% is probably more people 3 months, 6 months out and not treated. And there's also some evidence that the more, and I'll get into this later, I'm going to show you guys I'm going to show you one of the studies at least, that does show that sort of the more times you get COVID, the more likely you are to get long haul COVID syndrome. So it's actually not, and actually pneumonia. So we thought initially, we were like, well, it seems like maybe after you've had it, the second time will be more mild. And I have seen some evidence of that, but I think more of that actually has to do with the fact that the variants have become more infectious, but less severe in terms of their effects. But there are people who, but the absolute rate of pneumonia and long COVID actually does slightly increase. It's about a 10% increase per infection of risk of long COVID and pneumonia. So the idea is, again, more infections is what we want to avoid. And then early treatment with the full protocol is what I recommend to the vast majority of people. So I think that we want to try to minimize the amount of time you're exposed to spike protein. And with Ivermectin, it binds spike protein. It prevents binding to the ACE2 receptor. Hydroxychloroquine, it has a statistically significant reduction in time to viral clearance, which means shorter time to viral clearance means shorter exposure to COVID virus, which means shorter exposure to spike protein, which means less spikeopathy. And that's the term we're using now to describe disease caused by spike protein is spikeopathy. And one of the things that came out of that second FLCCC conference is we've got some cutoffs looking at specific antibody levels and where we typically see symptoms. Yeah, I can talk about that a little bit more if people have questions about it. But did that answer the question? I think that was from Pam. I see Pam, but she's not on camera. She can send a follow-up if not.
Okay, thank you, Dr.
Go ahead.
So the
Sure.
next question, have you had any success in restoring taste and smell to anyone who's lost it for more than 2 years?
Yeah, I don't know if we've ever had a patient that has come in 2 years after the fact and not gotten treatment yet. That's a good question. I will say that we've had 100% success rate so far restoring people's taste and smell. If we're treating that far out, we would do ivermectin, we would do low dose naltrexone, fluvoxamine for sure, because that's a neurological. Remember, smell and taste are neurological issues. And then we would also do a nutraceutical called R-lipoic acid, which is also called thiotic acid in Europe and South America. But suffice it to say that we definitely are going to need to take a more comprehensive approach, especially in someone who has had symptoms for 2 years. They need to also be on the more comprehensive nutraceutical protocol in terms of also being on fish oil and curcumin and quercetin and vitamin C and the probiotics, multivitamin, all the usual suspects. They need to really be dealing with their entire health, because we know that sometimes that with, for example, zinc deficiency, you can end up with problems with taste and smell as well, even irrespective of COVID. So if there's zinc, they're not getting enough zinc, or if they get too much zinc, that's the other interesting thing is zinc. There's a sweet spot with zinc. If you have too much zinc, if you're taking 100 milligrams a day for 3-4 months, you can actually depress your sense of taste and smell by overdoing zinc. Similarly, though, if you're deficient, you're not taking any for a long time and your diet doesn't get enough, which is most people, I would say, if they're not supplementing, then that can also cause problems with taste and smell, again, irrespective of COVID. So I would just say that there's hope for sure, a lot of hope, I would say, but I think that's a good question. I can't recall that we've ever had somebody who had not been treated for 2 years, but anyone we've treated has gradually recovered it. And that's the approach we use.
Thank you. I do have something to contribute to that as well. So when people were approaching us with that very problem, loss of taste and smell, Dr. Ryan and I spoke about it. And there's a couple choices: either provide the FLCCC protocol or really treat you as an individual. I always tell people there are no two people with the same genetics, the same environment, the same gut biome. We have to our intention, our commitment is to treat you that way so that it works. I think we have 100% success with people getting their taste and smell back because we come from that. We do a comprehensive lab draw with 100+ tests. Your primary care doctor will do maybe 5, and you can't see anything from such a limited view. And so we do that through our wellness plan. We make sure that it's comprehensive. We make sure that we're going in hard with what it is you're dealing with. So that's my contribution to that question. I'd like to move on to the next one. Are there any studies on the bad effects of the J&J shot? I hear much about the others. And so this person has written in anonymously, and I had somebody passed away suddenly in July, and he had that in April 2021. And what a tremendous loss, I want to say. And Dr. Ryan, will you please answer the question?
Yeah, I have something that will probably at least put your mind at ease a little bit, which is that the J&J, out of all the vaccines, actually had the best overall mortality benefit. So there was no net mortality benefit to the Moderna and Pfizer. They actually had there was a little bit in the 6-month post-market data. There was actually a little bit more people who died in the vaccinated group versus the unvaccinated group, even though there were more cases. I think in the Pfizer data, it was 11 times more cases of COVID in the vaccinated group, or in the unvaccinated group, sorry, unvaccinated 11 times more cases. Now, what I have later come to find out is that some of the people that were counted as unvaccinated were actually people who had 1 dose. So apparently they weren't vaccinated until they were 2 weeks out from their 2nd dose. That's vaccinated. If you're anywhere before that, you're still considered unvaccinated by the study. So that's a little bit of the mathematic trickery that happened. And a lot of those cases, actually, the unvaccinated cases did actually happen in that window between the 1st dose and 2 weeks after the 2nd dose. And that's why the numbers, I think, were as inflated as they were there, but in terms of the number of cases. But again, in both groups, the mortality, there was actually 1 more person who died. I covered this last year in our State of the Union. There was 1 more person who died in the vaccinated group, even though there were 11 times more cases in the unvaccinated group. That in of itself to me was interesting. But what was the question again? I'm sorry.
Question was, are there any studies on the negative effects, the bad effects of the
J&J? That's right. I was bringing it back around to J&J. So J&J, there was a group that did a sort of retrospective study looking at the 3 vaccines that we had in this country, including AstraZeneca, which they had in the UK, and some, which was similar to the J&J in terms of the technology. So it was an adenovirus vector vaccine where they took an adenovirus, which is commonly causing colds, right? And they put the spike protein on it and gave it to people. And that was different from the mRNA, which the mRNA was basically not really real mRNA. It was a synthetic mRNA that they created and then basically injected that inside of a lipid nanoparticle. And the idea was it was going to go and hijack your cell's own protein production mechanism and make spike protein. So very different. mRNA was brand new, fresh off the presses, never been used before. Adenovirus vector, that one has been used for several decades. They're not the typical vaccines that are given to kids, but a lot of the ones that are used in the military and that kind of thing. So that we had some pretty good data on adenovirus vector vaccines, and they generally have a net mortality benefit. Interestingly enough, having a mild cold probably increases your survival, even if you don't, or assuming you survive it, right? So if you survive it, it likely extends your life. And that's because during the cleanup process, it actually will repair some of the damage that is secondary or that's not related to the virus. But the cleanup process will actually clean up other cumulative damage that may have occurred due to other means. And therefore, you end up with a little bit of a boost in longevity. So the adenovirus vector, turns out the adenovirus vector vaccines in the first few weeks after people got them, they were associated with an increased clotting risk. And I don't think we're still 100% clear on why those particular vaccines did have that increased clotting risk involved. And to that extent, my understanding is that the effect of that was pretty much a 45-day window, 60 days at the most. So it sounds like your friend maybe died 3 months later. Possibly it was some mild spikopathy going on there. But again, the adenovirus vector vaccines did have a net mortality benefit. So the people who took them it was roughly equivalent to people who were maybe took ivermectin for early treatment. So that they had about I think it was a 60% reduction in death from COVID. That was alpha beta COVID. So I'm not telling you go out and get the J&J vaccine today. That was alpha beta COVID. It's a totally different spike protein now. That would be a useless vaccine to get today. But it turns out that for the people who did take it, by and large, it may have provided them some benefit. It was the only vaccine that may have provided some benefit, though. And today, we don't recommend anybody get any more COVID vaccines. No boosters. As Dr. Merrick likes to say, get a rooster, not a booster. That's his humor. Cracks me up, though. I love it. Anyway, I think that's the J&J. I'm not going to say definitely 100% couldn't possibly be related, but I would say it's the least likely of the three to be related to anything like that. And then your friend was also outside the window. A friend or family member, I'm not sure which it was, but is outside the sort of typical window in which we see a vaccine associated. Might it have contributed a little bit? Maybe, but it's impossible to draw that linear connection and say, oh, yes, that was definitely a victim of a vaccine injury in that particular circumstance.
Thank you.
Sure.
I am interested in finding out recommended doses of ivermectin and other supplements to be taken for treatment of someone with COVID and prevention of the virus.
Yeah, let's just go over that. Why not? With the FLCCC, we really look at prevention, treatment, and then there's people obviously who have long COVID. So I'm going to focus on prevention and treatment because that was the question. And I'll do a little screen share here. And this is directly from the FLCCC website. I'm going to go ahead and put this link in the chat so everybody knows our website, COVID19criticalcare.com. We'll look at prevention first, okay? So for prevention, we have this new Eat Guide to Fasting and Healthy Eating, which is not nearly as in-depth and comprehensive as what we do in our practice in terms of personalized nutrition, but it's a good starting point for the average person. Looking at prevention specifically with regard to COVID, flu, and RSV, which is what most people are wondering about, looking at the summary, which I think will give us what we need for today. I'm going to zoom in here a little bit. The recommendation, again, what I said, and I'm maybe a little bit more specific than they are here, but they basically say, look, not everybody needs to do preventive ivermectin anymore. If you've had COVID, if you don't have very many comorbidities, they say here, look, the following approaches can be considered and applied based on patient preference, comorbid status, immune status, and in discussion with their provider. So what I was talking about it earlier, I was talking about what we do in our practice and what I recommend personally, but I think these are reasonable approaches to take. If you are in that higher risk category, doing twice weekly ivermectin at the 0.2 milligram per kilogram dose. If you have comorbidities that are 2 or more, and or you haven't had COVID before, and or you're immunosuppressed, if you have cancer, you're on chemotherapy, or you have any other kind of immune deficiency, certainly if you have long COVID that's ongoing where you're still managing it, or post-vaccine syndrome, these are all very reasonable. If you're going to be traveling, going to weddings, big events, conferences, doing ivermectin just before and maybe even during, I think is also very reasonable. And then immediate initiation at the 0.4 milligram per kilogram dose at the first symptoms of a viral infection. Absolutely. And it says test or treat first, then test is what I always tell people. So you want to make sure that the first time, as soon as you get symptoms, get started on your ivermectin. Now, what if you've been exposed to someone? So we have standard prevention, which is what we just talked about, and then we have post-exposure prevention. When we do So I'm going to make a distinction. There's sort of the FLCCC protocol, but then when we do what we call a preventive prescription, what we're doing is we do these 0.2 milligram per kilograms for your particular weight. And then we do a 90-day supply, which is 26 capsules. So that's assuming you're taking it twice weekly, right? Now, what about post-exposure? And in terms of the pricing and all that, I'll let Madi talk about that later. But in terms of post-exposure, we absolutely recommend. So this is if you've been exposed to someone who had symptoms, or it turns out someone who's tested positive. It could be for COVID or even flu or RSV. This is useful. Elderberry is especially useful in flu, but the nasopharyngeal the sanitization is really useful for all of those infections. Vitamin C, zinc, melatonin, useful for all of those infections to prevent yourself from getting it. Resveratrol, especially useful in COVID-19. Now, what we do for patients who've had a confirmed exposure to COVID is we do ivermectin. We recommend, and this is a bit of a change from last year, is we do a 0.4 milligram per kilogram. So that's going to be 2 of the 0.2 milligram per kilogram capsules. We do 2 of those, and then immediately with food, specifically with fat. And then we want to do that again 24 hours later. And then we also do, so that's 24 hours later. It used to be 48 hours. Now we say just go ahead and do it again 24 hours later, because getting that high loading dose of ivermectin earlier on turns out to be more beneficial in preventing the development of symptoms. And then now we do hydroxychloroquine as well, 200 milligrams twice daily for only 5 days as a preventive. Or you can do nitazoxanide, especially if it's RSV that you've been exposed to. Nitazoxanide is likely to be more useful. When we do a post-exposure, we are typically doing, because we're talking about COVID post-exposure, we do ivermectin, hydroxychloroquine, and we do 90-day prescription plus 2 additional post-exposure doses. So that's going to be a total of 4 extra capsules, because you're going to take 2 capsules 24 hours later, take another 2 capsules. So that's your 4 capsules. And then 3 days after that, you go into back to your preventive dosing. So we do 30 capsules, and then we do 10 tablets of hydroxychloroquine. So that's enough for you to take it twice a day for 5 days. That's our sort of post-exposure protocol. This gets into vitamin D, and we do vitamin D testing as an add-on to any of our offerings, and also customized prescription in terms of a weekly dose, like a prescription vitamin D that you can take only once a week, and it will get your vitamin D level dialed in where it needs to be. So I'm going to go back to the FLCCC website. We're going to go back. I'm going to do this as if I were you, and then we'll go to treatment, because that was the other question. So we'll look at treatment. I am primarily going to just show you guys eye care, early COVID treatment, unless we have questions about the other ones. So eye care is early COVID treatment. Again, I'm going to zoom in here so we can really see this. In terms of the medications, I usually start most people, unless they're having pneumonia, shortness of breath, decreased oxygen saturation, then I will go up to a 0.6 milligram per kilogram for 5 days. But I do 0.4 milligrams for most people, starting that as soon as possible. COVID prep package is the best way to get that dialed in. And they say at least 5 days or until symptoms resolve. That's exactly what I tell people. I say, look, you want to take this until you're feeling well, like 95% of normal or better, for at least 3 days in a row, just to make sure you weren't having a good day and then the next day maybe not so good. So we want to see consistent wellness. And then you go to every other day for a week. And we do this sort of wean down where we do 0.4 milligrams per kilogram, so 2 capsules usually every other day for a week. And then we go back to the preventive dosing. I tell people for at least 2 weeks. And we find that really that came out of the fact that we had some people who would have return of symptoms as they stopped their ivermectin, if they stopped it too soon. So just weaning people down really helped absolutely minimize the risk of long haul COVID syndrome. The hydroxychloroquine, 200 milligrams twice daily for 10 days. So just to reiterate, so what we do for the COVID prep package, and it's a little bit different. If you come in with pneumonia, you come in at a level 3, and a level 3, you get even more ivermectin, because we need you to do that 0.6 milligram per kilogram dose. But I'm not going to get into level 1, 2, and 3, because you guys are here, you're being proactive, you're being preventive. So you want to get the COVID prep package so you're able to have all these dialed in and ready to start on day one of symptoms. And if you haven't already, I know a lot of people on this call probably already have a COVID prep package, which is great. But yeah, you take the ivermectin, 2 capsules, as soon as you have symptoms. And that's going to be that 0.4 milligram per kilogram dose. And you always want to take it with a meal, specifically with food, with fat rather. I will say that I don't usually see, so quercetin and ivermectin taken together increase the levels of both in your blood, which I would say generally is a plus. It's like you end up getting more of a benefit from both because they tend to be really safe. Now, occasionally, I would say maybe 2% of the time, maybe 3%, I have a patient who has what I think may be an ivermectin side effect, and then I will tell them to stagger their quercetin and their ivermectin. But I personally take them together, no issues. I'm the 99%, 90, maybe 98% of my patients are able to take them together, no problem. And then it actually, I think, is helpful because you're getting more bang for your buck because the quercetin and the ivermectin get to higher levels in your bloodstream and they're not eliminated as quickly. And I think that's a good thing. If these were not as safe drugs, then we may have to worry about that interaction. But I think for most people, it's not really an issue. Hydroxychloroquine, 200 milligrams twice daily. We do 10 days in the COVID prep package. But if you're well after 5 days, you can save your other 5 days for the next time you get COVID. Hopefully not, knock on wood, but you just, it's predictable that at some point you probably will get COVID again. Definitely best taken with zinc, taken with food. And I do it always together with ivermectin. Definitely we want to do acetylpyridinium chloride containing mouthwash. Chlorhexidine is another option, or you can do the 1% povidone iodine. You could also do hydrogen peroxide. It foams a lot, and most people don't love that, which I understand. But there's some people who are like, and I also am empathetic to the diehard natural, if at all possible, because I'm that way myself. I will tend to use the 1% povidone iodine for that reason, because I think iodine is in the realm of natural is pretty there. But if you use Scope or Act or Crest regularly, then that's fine too. Nasal spray, I like to do the nasal rinse with my patients with the NeilMed sinus rinse, but you can absolutely do the spray. I personally I don't use iodine because I have a really bad reaction to it in my sinuses. Some people do. You can use Argentin 23, which is a nano silver product. And that's the option that I particularly like. If you have a strong sensitivity to iodine, then that's what I recommend doing. All right, quercetin. I'm not going to go through every one of these. I am going to go into, let's see, where's vitamin D? Down here. Vitamin D, I use, calcifediol is really expensive. Calcifediol is one step away from D3, but calcitriol, the reason why they don't have it on the protocol anymore is because the therapeutic window is very small, so it's easy to overdose on it. But we only give patients 8 days worth. And so at that dose for that length of time, it's very safe. I've never had anybody have an overdose of the calcitriol because we just don't prescribe them enough for them to overdose on it. I do tell people if they've had vitamin D tested in the last 3 months and it was normal, which is to say between 60 and 80, or if it were high, which is to say over 80, then they don't need to take the calcitriol. And then fluvoxamine, they put this wonderful red warning on here. So now I have to get through that with people. But I will tell you that this acute anxiety, in treating certainly over 500 people now with this medication for COVID, I have seen this acute anxiety, I want to say 3, maybe 4 times. So I would say that I tell patients, I say, look, if you have acute anxiety from it, stop taking it. But it's literally, it's fewer than 1% of people. And it's actually what we call a paradoxical reaction. So it's the opposite. Most people actually will find anxiety goes down when they take fluvoxamine. 99% of people, their anxiety will actually get better on fluvoxamine. 1% of people will have this paradoxical reaction. It's pretty rare. I have seen it a handful of times and certainly have never seen it progress to mania or violent behavior. Long before that happens, we take people off of it. If you're feeling panic symptoms, if they're feeling anxious, we just take them off of it. And we certainly never prescribe it for longer than 2 weeks, except at a very low dose using a different protocol for long COVID, long haul COVID. Sometimes we'll do 25 milligrams once a day for a month or two in patients who have neurological long COVID. But yeah, everybody gets fluvoxamine for 15 days as part of our PrEP package. And they can choose to take it for a week or 10 days. Usually I tell people take it for 10 days. And then if you're feeling well after 10 days, you don't have to keep taking it. Okay, so that's just to recap. COVID PrEP package is fluvoxamine and ivermectin, hydroxychloroquine, and then calcitriol, which is that active form of vitamin D. So D3, which is the commonly available over the counter, that can take months to get your level up. And in fact, the studies on it have shown that in acute COVID, the calcitriol works about, I'm going to go back to my screen share because I do enjoy my screen shares. This is from my favorite website, c19early.com. And we see here vitamin D in terms of bang for your buck is one of the more effective treatments. It looks like they've changed the site since the last, oh no, here we go. Yeah, treatment with calcifediol or calcitriol is more effective than cholecalciferol, which is D3, 65% versus 38%. This is just your standard D3, 38% improvement, 65% improvement with the active form. And so that's why we use that form as opposed to D3 in acute disease. Now for prevention, definitely D3 is what you want to use. Okay, great. What's the next question?
All right. The next question is, hi, Betsy. Would it be appropriate to discuss the new protocol that Dr. McCullough offered to DVAX? And yes, any questions are welcome. We can be with anything, and you can ask however you want to ask and whatever it is that you want to ask. Dr. Ryan.
Yeah, that's not one of those that I have ready, but I would say that I know that the main difference from what I recall with the McCullough protocol on his website, he likes to use basically, it's called famotidine. And famotidine is an acid blocker. It's a H2. And there is some evidence for famotidine in COVID. We see statistically significant lower risk for mortality, hospitalization, recovery, and viral clearance. It's pretty modest, right? It's not like this is not a super effective treatment by itself. Do I think it may have some benefit along with everything else? Yeah, the evidence is there that it does. I think it's not part of the FLCCC protocol just because the effect is not super high. And I will just tell you that from my perspective, I try not to prescribe acid blockers to too many patients just because I find that it impairs their absorption of other nutrients. And so my concern would be, are they getting as much zinc absorbed if they're taking an acid blocker? Because we need stomach acid to solubilize the nutrients. I'm not doubting the evidence for it. I think it's there. There is some evidence that people taking it due to acid reflux and other issues may have a slight reduction in risk of getting COVID. As an early treatment, there's only been one study looking at it, one study of 55 people, and the result was not statistically significant. In late treatment, I use it in late treatment. The result is still not statistically significant, but I do use it in people who have COVID pneumonia. I do prescribe famotidine because at that point, you're throwing the kitchen sink at them. And it also helps protect their stomach. If somebody has an aspirin sensitivity, famotidine can help. If we have to use a higher dose of aspirin, I'll do the famotidine along with it, especially if we're doing corticosteroids at the same time. I'm not anti-famotidine whatsoever. So this is McCullough protocol. This is a nice little graphic here. Let's take a look at this here. This looks like mostly for prevention or treatment, but he has a zinc vitamin D3, which again, that's going to take a while to affect you, but it's certainly not a bad thing. Vitamin C, quercetin, and he adds the famotidine in, which I mentioned. And then he likes to do monoclonal antibodies really are not really a thing anymore. And then he adds in HCQ. He likes to do azithromycin because it's also got some zinc ionophoric properties, so it helps zinc get inside the cells. Azithromycin has also been associated in multiple studies with fatal atrial fibrillation. It used to have a black box warning, and then somehow they got it taken off. And In my practice, I have seen a fair amount. So I inherited a practice from an old GP who was practicing for 40 plus years in San Diego, and he prescribed a lot of Z-Paks. That azithromycin is Z-Paks, and he just prescribed them like candy. And what I found was a lot of his patients had AFib. And so I had to go about treating the AFib. So I kind of soured a little bit on azithromycin. I still use it if it's the best antibiotic for the situation. I mean, I had to give it to Maddie. She got whooping cough when she was pregnant with our first child, and azithromycin was the safest medication for her to take while pregnant for the baby and for her. I will prescribe it, but to me, it's not as safe as hydroxychloroquine. And HCQ is a much stronger zinc ionophore than azithromycin anyway. If I see someone and I suspect a secondary bacterial infection, I will absolutely add in doxycycline at 100 milligrams twice daily, which is what he says here. And because there is some evidence that ivermectin and doxycycline have a synergistic effect, that they really work well together. We use ivermectin with the HCQ, and obviously I go beyond 5 doses. And then, and he says actually equal or greater than 2 of anti-infective agents. And then he says, well, you could use these Paxlovid or molnupiravir, but I don't really use those at all in my practice. FLCCC does not recommend them because we view them as overpriced and under delivering in terms of their efficacy. Basically, the risks outweigh the benefits. And then if we get respiratory symptoms develop to do in nebulized budesonide, I was doing that 2.5 years ago. So I was one of the first people to use nebulized budesonide in our practice. There was a fellow physician, I forget his name, in West Texas, but he started doing it, and then I started doing it like right after I heard from him that it was working. And so I said, that makes sense. And then it was later actually approved by the United Kingdom in terms of their COVID treatments. It's one of the ones that they have on their list. And then these other steroids, in terms of when they're used, it is typically if somebody has prolonged disease or symptoms that are lasting. Usually I would say not beyond day 5, but I would say beyond day sort of 14-ish or of symptoms. Or especially if they're having shortness of breath on exertion, or they're on treatment for 5 days and they're not getting better, that's when I maybe would put in some steroids. So it is very patient specific. Colchicine, you cannot combine that with ivermectin, so I really don't use it at all. But if you, for some reason, couldn't get ivermectin, but you could get colchicine, it may have some benefit, but it's not as strong of a benefit as ivermectin. So colchicine, again, helps, but results in early treatment, not super great, not statistically significant as a preventive or an early treatment. May have some benefit in late treatment, but again, mostly what we're trying to do with most people is prevent them from getting late disease. All right. And then, I use aspirin in everybody, but in patients who have more severe disease, we will use low molecular weight heparin for sure, or one of these oral anticoagulants, especially if they have any signs or symptoms of a blood clot. And I usually combine those with CSIS plus or minus, but we usually do the plus. We'll combine it with aspirin. So this is McCullough's protocol. It seems for COVID as an illness. Maybe if you can send it as a link in the chat to his I think you said it was a DVAX protocol, right? So it probably includes resveratrol, a lot of the things that we use, FLCCC uses. Definitely
I've got it. So there are 3 over-the-counter medications: so curcumin, pineapple abstract, bromelain, and natokinase.
Nattokinase, yeah.
Okay.
So we use all those in our vaccine injury, depending on the situation with patients. We may use any of those. Usually nattokinase, I think, is going to be a lot more effective than bromelain. Although bromelain we use a lot in acute COVID if people have sore throat or muscle aches, body aches, headache, any kind of aches and pains. It's really bromelain, think of it as like the natural alternative to ibuprofen, but it has to be taken on an empty stomach, because if you take it with food, it's going to be a digestive enzyme. So it's a good anti-inflammatory. I certainly see no problem taking that. It may have some spike digesting effects. Sure, why not? It's very safe. The other thing I would say is curcumin. That's part of our acute protocol as well as our long COVID protocol. So no problem with that either. And interestingly enough, regarding bromelain, back to bromelain, I was using that. It's always funny. I always have the joke. It's like if whatever Dr. Partovi is using, FLCCC will add it to their protocol in about a year. But we were using bromelain a couple years ago, at least. The other thing I would say about nattokinase is really smart. I use that historically pre-COVID for patients who have really severe increased clotting risk. So people who had a history of DVTs, deep vein thrombosis in the legs, or pulmonary embolism, if they're like, hey, I want to get off of my Xarelto or Apaxaban or my oral anticoagulant, but I want to do something natural and I want to clean up my diet, and what are my other options? Nattokinase is actually derived from natto, which is a fermented soybean paste kind of. It's in the same family as tempeh and miso, if you've had those. But nattokinase is an enzyme it's a really pretty effective anticoagulant and can be taken long term in patients who have increased clotting risk. And so it does seem to help. I think a lot of the people who have post-vaccine or long COVID are actually people who have microclotting from the spikopathy. So I think it's probably both helping it maybe to digest some spike. I think that's more of a theoretical mechanism, but I would say it's also helping to thin the blood a little bit, which is helping the body recover from the spike damage as well. So it's kind of a two-part. So I think that's great. I think those are all great things, and I prescribe them in patients who have long COVID and or vaccine injury. Do I think everybody who had the vaccine needs to take those? No, because I think at this point, if all you had were the first 2 doses, there is a modest effect of that at this point. But I would say over time, what you're going to find, if you just had the first 2 doses, whatever your risks may be, the difference between you and an unvaccinated person is going to decrease over time, right? So the real issue is we're finding in people who are getting boosted upon boosted that have had 5 or 6 doses, those people continue to have persistently increased issues. And I'll talk a little bit more about that. I just had a couple things I wanted to share with you guys about that, but let me know when we're ready for that, Maddie.
Next question is from Chrysalis, and thank you for being here, Chrysalis, and being part of our community. What do you recommend for protecting against vaccine shedding?
Yeah, so that's a really good question. Vaccine shedding is pretty, amongst the doctors that are FLCCC, Dr. McCullough, and allied physicians, I would say shedding is something that is really embraced at this point. It was something we were skeptical of initially, and now we're sort of like, no, that's a thing. I would say that with regard to shedding, your best protection, if you're someone who's got long COVID or someone who's very sensitive to spike, even exposure through the mucosa, which is eyes, ears, nose, mouth, anus, vagina, penis, etc., is preventive ivermectin. Now, does everybody need to do that? No, because all those mucosal areas I just mentioned have a specific part of their immune system. Our immune system is called the mucosa-associated lymphatic tissue, and that tissue produces IgA antibodies against spike protein, and that will actually help bind up that spike before it even gets into the body. So even if you're getting shedding of spike from somebody else that you're exposed to, as long as it's not getting injected, you should be good. But here's what I'll say. People who have long COVID, it's a different story, right? So what I will tell you is that we've also seen patients where let's say the wife has long COVID, right? And then the husband was vaccinated. And we're treating the wife and she's not getting as better like we would expect, right? And then we do analysis of the husband and come to find out his anti-spike protein antibody titer is super high, which means he's still chugging out spike protein. So even though we're treating her, she's getting re-exposed every time she touches him or is in close proximity to him every single day. Every night she gets another dose of spike right through him. So until we treated him, she really didn't have the kind of improvement we would expect. So again, shedding is a real phenomenon. But yeah, in terms of how we would treat that, we have to treat basically both people in that circumstance for long COVID using our protocol. And it would include things like quercetin, curcumin, resveratrol, nattokinase, a lot of those things we've already mentioned. But I would just say that ivermectin, at least for a time, we don't say ivermectin forever, although some people do benefit from ivermectin forever, especially if they have a personal history of cancer or they're past the reproductive age, so they're over 50. In women, frankly, I don't know if too many men over 50 should be having a lot of kids, but that's a whole nother conversation. But the point is really that it maybe is, there's really no downside to being on ivermectin. And I would say that would be it. But yeah, we don't recommend people take it ongoing if they are trying to get pregnant. That's the one group that we say that, and people who've had an organ transplant would be the other group. All right. Did that answer the question?
Yes, Crystal, go ahead and let me know in the chat if that answered the question. In the meantime, we'll move on. The next question is from Grace. Hi, Grace. Good to see you. Have you seen more kids with constant coughs since COVID? It seems like grandkids and their friends are always sick. Any recommendations? So I have something to say because this has something to do with our kids. Grace, this is really an opportunity for parents to up-level the way that they feed their kids, the way that they administer any kind of medications to their children. I would recommend finding out what blood type these children are. I would start them on the blood type diet. I would clean up their diet and look for anywhere that there's refined sugars and just eliminate that. There are so many beautiful substitutes available. I would look at going grain-free or largely grain-free, because those are just fillers. There's nothing nutritional about those things. And I would take a look at the prior email. I could resend it to you. But Dr. Ryan created an age-based from 0 to, I think, 16 with the optimal nutraceuticals that he recommends for children. That's what we give our children. Our boys are grain-free. They're largely paleo kids. There's no refined sugar in this house. So it really is an opportunity to up-level and we have a 1-bite rule too. Sometimes kids get a little finicky, right? 1-bite rule. And it starts to develop their palate. The other day, I was just looking at my son eating spoonfuls of hearts of palm rice. I was like, okay, this really works. So it really is an opportunity for parents to stand for their children and to really get educated on what works, especially in this time, in this COVID era. It's not going away. So that's what I have to say. Thank you. Dr. Ryan?
Yeah, I think the only thing I would just put a slight caveat on there is that we have a type O bias in our house because we're all type O's. Grains, there are people who can eat grains in a way that's healthy, especially if they don't have blood sugar control problems. I personally have a tendency toward blood sugar control problems. I've had pre-diabetes since I was 19 years old. And we can get it, and that's actually a great segue to my answer to your question, what I'm going to add in. But because of that, we are grain-free in our house. And certainly there are grains that are better than others. If you're going to have grains, they should be organic. If you're a type O, you should avoid gluten. If you're a type A, spelt is still a better choice than whole wheat. And there's a lot of information out there about that. But yeah, I think that grains, by and large, are not as nutrient dense. And that's what Maddie's really getting at. They're not as nutrient dense as some of the other options. And I think that's a valid point. Should be emphasized. And what I would add to the nutritional piece and the nutraceutical piece, because yes, it's true, we live in a world where regardless of what you're eating, even if you're eating 100% organic, unless it's biodynamic, they're not using manure as fertilizer, they're not doing tilling under, crop rotation, the kind of farming practices that were used for thousands of years in human society. They're basically spraying, even if they're not spraying pesticides, they're still using potassium, nitrogen, phosphorus on the soil and just continuing to use chemical fertilizers that basically don't nourish the soil. So you get a lot of topsoil runoff, you get mineral deficient food, and then as a result, you end up with vitamin deficient food. So that's one of the reasons why we recommend supplementation for everyone. That and the fact that our toxic burden, and that's a perfect segue to my answer to this question, is that our toxic burden has never been higher as a society. There's I think over 45,000 new chemicals that have been introduced since the end of World War II into our environment. And I think any one of us has an average of, I think it's at least 250 floating around in our bodies at any one time. Kids being the most vulnerable are going to have those vulnerabilities. And I appreciate that fact that one of the things I really like about when I hear Robert F. Kennedy Jr. speak is that he talks about the red line in terms of childhood chronic disease. When he was a kid, the rates of childhood chronic disease was like maybe 5-6%. It was really low. Now it's like 46%. And he says, so when Congress asked EPA, CDC wasn't going to give them an honest answer. So they asked EPA, and EPA said it was a red line. It was 1989. That's when it happened. And so then there was a toxicologist who took a look at what are all the potential environmental. It's got to be environmental. It can't be genetic. There's no massive change in genetics in 1989 that would account for this chronic disease explosion. It has to be some sort of environmental exposure that people are being exposed to that they didn't used to be exposed to. And so he points out that this toxicologist looked at everything and he said, look, it could be certain chlorinated pesticides, organophosphates, could be specific ones. I think glyphosate may be one of those as well, which is found in Roundup, also known as Agent Orange, the original name. And then you've got PFOS, which is used as a flame retardant. It's used in AstroTurf, which they're now putting in a lot of children's playgrounds. And also, I think it's used in some nonstick coatings on certain pans as well, and possibly even flame retardants in like pajamas. My wife was telling me that they're in pajamas now, some kids' pajamas. That's a potential new exposure. And then Wi-Fi and cell phones, especially close to the body, is a concern, possibly. I can tell you the WHO has said that cell phones are a probable carcinogen. So that's their way of saying you can't sue because we told you they probably cause cancer, right? The cell phone manufacturers are protected, but that doesn't mean you are. So letting kids play with cell phones, we try to keep our kids away from cell phones as much as we can. When you're developing, it's much more likely you're going to be affected by these things. And then vaccines, there was a huge uptick on the schedule in 1986, which is 3 years before 1989, which is where you would see that, okay, so it takes a few years for some of these effects to manifest. And so the childhood vaccination, they passed a new law in 1986 that basically said you can't sue vaccine manufacturers if you get injured from a vaccine. You've got to go to this special court. And so the court is going to be funded by taxpayer dollars, and we're just going to take care of people. But there's a whole process, and you have to go through it. So even if you think you have a vaccine injury, it's not like an easy, I'm just going to go apply, and they're going to send me a bunch of money. It's like you have to hire an attorney and actually go through the process. What we see is that to me, out of all of those exposures, to some degree, a lot of those things are things which our body, maybe not the Wi-Fi, but most of those chemicals are things which our body has mechanisms of dealing with that are ancient. They're compounds, there's chlorinated compounds found in nature. We don't normally get exposed to them as much. They're things which we're used to. What we're not terribly used to is foreign antigens getting injected directly into the bloodstream or into the organs or into the muscles or whatever. That to me is the one that I think is, and I think RFK Jr. talks about this, is why he gets called an anti-vaxxer, even though my view is he's a skeptic and is an advocate for vaccine safety, which is, I would put myself in that camp. I'm an equal opportunity skeptic. I'm as skeptic of the official line as I am the stuff on the fringes. I view everything with a fair dose of skepticism versus I think a lot of people who call themselves skeptic are saying if the middle 65% of society agrees on this, I'm going to agree with all that too and only attack the fringes. And I think that's a little intellectually dishonest. Anyway, I think that I find a lot of the information that RFK Jr. has brought to light regarding childhood vaccines to be really interesting. And I think it's something that where I find a lot of that information to be pretty compelling. And I think it's enough that I would say that in my practice with my patients, I tend to take a more nuanced, what I call smart vaccination approach with kids and parents. I actually go over the vaccine safety data from CDC, which everybody's supposed to do, but we've certainly, Maddie and I have never experienced that. And I would say that any parent that I've talked to said, no, I've never had anybody go over a CDC document with me when my child was getting vaccinated. They just said it's time to get them a vaccination, and here's the dose. And there's supposed to be a whole informed consent process that goes along with this, where they talk about pros and cons and evaluate the potential side effects so that you can know what's going on. And I will just say that, and also look at the risk of getting the particular infection that we're vaccinating against, and what that risk actually is in reality. Like, what are the risks of actually getting that disease? And even if you were to get it, do we have a treatment? What would that treatment look like? Those are all important questions. And so I think to get a really holistic take on it, you have to start asking those questions. And that's one of the things I appreciate that he's done. And I suspect that my sister is only one of the three of us, like my generation of my siblings. I have a brother and a sister. So she was the youngest. And so she was the one who got, the only one of the three of us who got those additional vaccine doses. This is an anecdote, right? It's just, I'm going to tell you a story about my personal family experience, right? But it's interesting because we all have pretty similar genetics. At least half of our genetics are in common, right? And that may be confusing to some people. So when your parents are recombining, there's a lot of different ways their genes can recombine, and you share on average 50 siblings, full siblings share on average 50% of their DNA. That's why they're not clones. They're similar, but they're also different, right? I think my sister and I, it's like 58%, and my brother hasn't done the 23andMe, so I don't know what his percentage is, but it varies sibling to sibling, interestingly enough. So you may be more related to one sibling than you are another, and that could be genetic. It's a random sort of luck of the draw thing. But I would say that, interestingly enough, my brother and I, actually had a vaccine reaction as a child. My pediatrician, this was back in the early 80s, where they were still doing multi-dose vials. And what he did for my second and third shots was he just pulled a little bit from the vaccine jar, filled the rest with saline, and gave it to me so he could say, I gave it to him. But now you can't do that because everything's preloaded syringes to protect you from infection, right? Because supposedly these multi-dose vials were causing these infections. I don't know if that's true, but I do know that now we can't customize the dose of the vaccine for children. So what we do in our practice is we test kids. We do titers. We see, do they need a vaccine? Do they already have titers? Are they protected? Because the other thing they don't tell you is that about 85% of people are protected. They have protective levels of the antibodies after one dose of the vaccine. We're talking about like MMR, right? Measles, mumps, and rubella. And then they give the second and third shots because at the second, it's 95%. At the third shot, it's 99%. So they say, okay, good. After 3 shots, you're protected. But yeah, I would just say that when it comes to understanding childhood inflammation, which is really what you're talking about, because if they have chronic cough, it's because of chronic inflammation. You've got to look at environmental exposures, which broadly are going to be man-made toxins, biotoxins, which biotoxins have been around for thousands of years. There may be some building materials we're using that are different, that are causing mold to grow more often inside of buildings, water damaged buildings in particular. That's a separate topic. But, man-made toxins, what we call toxicants, including heavy metals, biotoxins, including spike protein from COVID. And then we also have to look at, and I would put vaccines in that, broadly speaking, in that category, at least over vaccinating. A lot of these people don't have reactions until the second or the third dose, right? And it'd be smarter to just test people after the first dose, see if they're immune. If they're not, maybe give them a second dose. If they're immune, then just one dose is plenty. I'm talking about for kids, right? For these different diseases. That smart vaccination approach is what I typically advocate if people want to get their kids vaccinated.
Can we do that through our pediatric wellness plan, Dr. Ryan?
Pediatric wellness plan is really not designed for that. Pediatric wellness plan is really to get kids on a program of just optimizing their health. It's really just, okay, what's your blood type? What's your secretor status? Here are your dietary recommendations, nutraceutical recommendations. And then if you get sick 2-3 times a year, then we see you inside of that. That's what I believe we had discussed. So I don't know if we do vaccine counseling inside the pediatric wellness plan. It seems like that would be a little bit beyond that, but you're the boss, right? So if you want to do that inside the pediatric wellness plan, we can. It may need to be an add-on though, because it's not something we discuss. So we'll talk about it.
All right, we'll talk about it,
Yeah.
Grace. Thank you so much for your question. All right, Kaoru, hi. So glad that you're on. Kaoru has our COVID prep package, and she's asking, she also has naltrexone prescribed by you last year. If I get COVID next time, at which point should I take the naltrexone?
So I prescribe naltrexone if you have symptoms beyond fatigue, because sometimes fatigue can linger a little longer, and that's normal. But if there's anything usually beyond fatigue at day 21 is when I will recommend starting naltrexone.
Thank you. All right, a direct question. My 25-year-old son, never vaccinated, never boosted, has had COVID for a week. He's overweight. Any recommendations? And I will start off as practice manager that treatment is optimal. Active COVID treatment is optimal. And I could have Anna reach out to you with details. And I think Dr. Ryan answered in the very beginning why active COVID treatment is the way to go.
Yeah. And we're still seeing that. We see that every day where people will come in and they've had symptoms for 5 days, 10 days, 14 days, and they've waited because they're like, oh, I've had COVID before, I'll be fine. But then the second or third time they get COVID, it's actually worse. And they're like, what the heck? I don't understand this. And in fact, there is evidence for that. Like I mentioned, it's modest. It's like a 10% increased risk with each time you get COVID, but it's still an increase. So, I would just say that given that early treatment remains our top recommendation for everybody, regardless of age, comorbidities, anything, I say do 5 days of treatment, whether you think you need it or not. And that's my number one recommendation. If you leave this call with nothing else, just leave with the understanding that if you get COVID, you should absolutely treat for a minimum of 5 days. That's like my number one message to you guys. Well, that and get a rooster, not a booster.
Okay. All right. Thank you. Is there any way to test for spike protein levels after having COVID?
So what we can test for, that's a great question. So the way you test for spike protein levels after getting COVID, there's 2 ways. One is a biopsy, which is no fun. Nobody wants to get a piece of tissue cut out to see if there's spike, but they can literally stain it for spike protein to see, is there in fact spike protein here or not? That's part of how we know that spike protein gets into the tissue. And I could get more into how they do that if you guys are curious, but I'm not going to go there for now. I would just say that the other way, which is the way we do in our practice, is looking at the antibody response. So if we see an antibody response that is greater than 3,000 on that anti-spike protein antibody titer, that's where we suspect that there's chronic, either possibly autoimmunity induced by spike protein or chronic spike protein exposure. But certainly when I would say someone's symptoms are more likely to be due to either vaccine or post-COVID, their spikeopathy, right, is when we see that titer at 3,000 or above. And I am seeing that in my patients that are unvaccinated. I typically don't see that. I typically find that they will usually have a nice, healthy, robust 800, 900, 1,000, even 500, fine. But in patients that have had more boosters and also who had long COVID, will typically have higher than 3,000. And that's where we say, and we can get into that and parse it out. There's different tiers of like, okay, but if you're over 25,000, then you probably have debilitating symptoms, right? So there's different levels of titer, but that's really how we check. We check to look at the titer levels. Make sense?
All right. Next question from Brenda. You stated that someone who has had COVID once and now no longer has comorbidities or issues that we don't need to take preventive ivermectin. Instead, you're recommending the COVID prep package. Is this something that should be taken regularly, or is it to be on hand just in case one gets a second or third case of COVID?
Great question. Assuming you're not working on the floor of the COVID floor of the local hospital, assuming that there's no other chronic condition you're dealing with that for which you may be needing to take ivermectin or for which ivermectin may be beneficial. So that's actually an interesting area, which I think we have a particular plan called the Preventive membership, which is basically you can get an ivermectin refill whenever you need it. And the use of that is especially, it's not just for people who want to prevent COVID. It's for people who may have a chronic disease, whether it be they have cancer, they have cancer in remission, they have fatty liver disease, maybe they have hypertension or cardiovascular disease, and they found, or autoimmune disease, and they found, oh, gee, when I was taking ivermectin, when I was during my COVID treatment, I found that my autoimmune disease was much better, right? And when we see that in the studies that have looked at it long term, that there is improvement in autoimmune symptoms for people who are taking ivermectin even just once a week. And improvements in blood pressure, kidney function, liver function, blood sugar, we see that. So diabetics. So again, there's a group of people who do in fact benefit from being on it long term, even just once or twice a week. And so for those, I would steer them more toward, I would say, yes, get a COVID prep package, but then also when you start running low on your ivermectin, because we give you 30 capsules with 2 refills, which you can go ahead and take preventively. And then when you get towards the end of that, when you're on your last refill, reach out to us, sign up for the preventive membership. And then that way you can continue to take it once or twice a week, and we can refill it for you whenever you need to refill. And that currently is, I believe, only $30 a month. It's about to go up a little bit. Spoilers. Sorry, I don't mean to steal any of your thunder, Madi, but people who are here or basically who lock that $30 a month price in within the next few weeks before the end of the month will have that price for a year. So that's nice. Speaking of prices, I'm not usually the finance guy, but I can just say that we have not raised our prices since day one of the pandemic. We've had the same exact prices. Unfortunately, we can no longer do that. It's really reached a point of critical mass where, inflation is just out of control, and we're going to have to announce some price increases. We've been putting it off and put it off and put it off, and we put it off for about a year at this point, I think, haven't we, Madi?
But yes, and they will still be accessible. That's still our
commitment. Absolutely. We literally took the prices and adjusted them for inflation, and that's it. We're not actually raising them relative to, we're not gouging. Yeah.
We're not doing the highway robbery.
We have seen some highway robbery. That's why we mentioned that.
Okay. So Deborah, I had the J&J shot in May of 2020. I had flu-like symptoms for 2 days after the shot. Then I've been okay since. Should I still do the detox, the natto, the bromelain, the curcumin, just to be safe?
I don't think you need to. I think at this point that curve is, are we ready for me to get into talking about the curve so I can?
I'm just going to go through, I'm going to cut off the questions right now. We'll answer the rest of them.
Okay. So I'm going to go over it in a little bit, but I would just say that basically that difference between the people who got the first dose of J&J or the first 2 doses of Pfizer, Moderna, and unvaccinated is decreasing over time, right? And we see that those lines are converging over time. The real issue is in people getting 3, 4, 5, 6 doses, right? I would say if you want to do a couple weeks of bromelain, nattokinase, I would add resveratrol in there, curcumin. It certainly couldn't hurt. I take curcumin fairly often, not every day. I take quercetin every day. I have a lot of patients that take curcumin every day, though. My mom does. It's a really great long-term anti-inflammatory to be on, especially as you get older, just to help with joint inflammation and all those kind of things. Bromelain, I think doing a couple weeks of that's not going to be a problem. Nattokinase, a couple weeks of that's not going to be a problem. If you want to just, I don't think you need to keep taking it forever unless you have clotting issues, then maybe nattokinase can be useful. If you do have, some people who have autoimmune conditions, I'll put them on bromelain, maybe not at the full dose. I usually use it more for people who have a flare, right? Let's say you have lupus and you're having a flare. I will do a high dose of bromelain, 4 capsules 3 times a day if you have COVID, and then I'll gradually wean it down over the course of as their symptoms improve. I think that a couple weeks of those things is likely to be only helpful and reasonable. Yeah, hopefully that answers that. If not, send us a follow-up.
Great. So I want to circle back to the loss of taste and smell question. This person went to the ENT immediately. They weren't treated aggressively. They were prescribed Flonase, vitamin A oil. She went again a year later and was told to use essential oils for smell therapy. And the doctors in New Jersey are very hesitant to deal with anything related to COVID or vaccines. I take vitamins for years, Life Extension Company, and in between a blood clot and frozen shoulder. So the taste took a back seat to the other issues. I also had a very comprehensive blood panel done by a rheumatologist. All came back normal. I do have something to say right out of the gate. We get a lot of all came back normal from conventional doctors. And here you are, you're still dealing what you're dealing with, loss of taste and smell. You're still dealing with whatever it is along the health and wellness spectrum. We get a lot of that. And if you have a perspective that's a very small piece of the pie, you see through a certain lens, right? And there's only so much that you can see. So when Dr. Ryan does your labs, and when he sits with you for those 2 to 3 hours, interpreting and discerning those labs, and then creating a pathway and an access for you to take the 1,000 actions that are possible for you to have a life of vitality and aliveness, it is a very different game, very different ball game. And we would love to take you on. We would love to take you on as a patient and have you get your smell and taste back, because it is possible in our realm of practice. Yes.
Yeah, I just want to say, first of all, I love my wife. I love her passion and her commitment to our patients. And for anyone who may have been overwhelmed by 1,000 actions, I think that there are probably 1,000 potential actions, but I don't give anybody 1,000 to start with. Usually it's maybe a dozen or two at the most. And then just specifically to that, I would want to just say that Flonase is likely to be counterproductive in this particular situation. I don't recommend Flonase really for almost anybody. It's one of those medications I think it should never have been made over the counter. It typically, because it is a steroid, it thins the mucosal lining, and so it increases the vulnerability of the mucosal lining to things like spike protein, and as a result could actually worsen symptoms over time, because by making the tissue more vulnerable, it's allowing for potentially increased damage to occur. So no more Flonase. If you're having a safer drug to take, if you need to take a drug for allergies or that kind of thing, sinus-related issues would be like your Allegra, Zyrtec, Claritin. And you can usually dose those higher than what they say over the counter. So you can take one twice a day if you find that you need that. That's not a big deal. But I would say that taking Flonase on a regular basis, I wouldn't recommend that for anybody, much less somebody with loss of taste and smell. I understand theoretically why they would do that, because they're worried about sort of inflammation being at the source of that. But when you actually paralyze the immune system, which is what corticosteroids do, you freeze the resolution of that inflammation in place. You don't actually allow it to complete and then the healing to begin. Yeah.
Thank you.
Sure.
Husband, I love your calm and steadiness. And it's a great balance to my fire and my passion. Okay. Grace is asking, can low vitamin D cause dizziness?
Low vitamin D cause dizziness? I don't know. I think it's important to say that when you don't know. I've not heard of it. It's one of those things. I think usually we think of it as causing immune problems with immunity, bone problems, not necessarily dizziness. But apparently, yeah, that's what I'm seeing. A quick Google search reveals that, in fact, vitamin D on intensity of BPPV symptoms. So this is PubMed. And influence of supplemental vitamin D on intensity of benign paroxysmal positional vertigo, which is BPPV, a little bit different from dizziness, but it's in the same realm, and it can cause vertigo. And it's linked to vitamin D deficiency. And then what they found was 2 months of treatment, both vitamin D treated and non-treated groups, apparently they both got better, but that says intensity of symptoms regressed to the baseline vitamin D treated group. So basically, they got better, then they got worse again if they weren't treated with vitamin D, whereas if they were treated with vitamin D, they remained stable and unchanged. So they actually got better and then stayed better, right? In addition to the Epley maneuver, which is the standard treatment for BPPV, they're recommending vitamin D correction, serum measurement, and correction. Yeah, and just you're going to find here, and I was wondering what the mechanism would be. I suspect it may have something to do with calcium levels or phosphate metabolism. Yeah, helps maintain otolith organ function. There you go. So the answer is yes. And I learned something today, so that was cool. Always love that.
All right. And we can support you with your vitamin D levels.
Yes.
Okay, from circling back to the shedding question from Chrysalis. On the more natural side of prescriptions, I've heard that pine needle tea and homemade quercetin made from boiling grapefruit and lemon peels can help protect against vac shedding. Are these comparable treatments?
In terms of homemade quercetin, I'm not aware of any natural source that's going to get you the kind of concentrated level that we use nutraceutically. It is found in a lot of different fruits and vegetables. I don't think that pine needles are going to give you anywhere near still the level that we use in nutraceuticals. The grapefruit component, my understanding of that was that it was more about the peel, rather, is more about there's some natural level of chloroquine in that, which is hydroxychloroquine as a synthetic version of that. As a result, I would say that maybe is more useful on a post-exposure basis. I don't know about prevention. And again, I don't know whether the level is sufficient to make a real difference. I would say that I personally wouldn't rely on those strategies. Are they likely to be harmful? Probably not. But can I guarantee that they would be as beneficial as taking quercetin as a nutraceutical formulation? And I like the one that we use in our practice, Quercesorb, because it has particular absorption enhancing components with it. It's a highly absorbable form of quercetin because sometimes that is an issue. It's also important to take it with fat, I would say. Anyway, I would say to do that sort of under your own recognizance, would I say, should you rely on. Now, here's what I will also say, though. Is it true that, for example, grapefruit juice and has the ability to, I may say the wrong thing here, but I believe it actually impairs P glycoprotein function. So it actually blocks the excretion of certain drugs. And so it may increase the levels of certain medications, and that it may include certain pharmaceuticals. Yeah, absolutely. That's true. And so I think that grapeseed extract has antifungal properties. That's the seed of the grapefruit seed extract. And is that something that is going to necessarily impact COVID? I would say not really, but I'm not, in other words, I'm a big fan of grapefruit and all of its many different forms. And I know that the peels of citrus do have some natural chloroquine. I don't know what the levels are, though, if you're doing home extraction. And it seems to me like you would need to do alcohol extraction if I understand the chemistry. I don't know if water extraction is going to work for chloroquine, but I wouldn't rely on it just because the chloroquine that comes from one particular grapefruit may be very different from the skin depending on where it's grown, the particular variety. You're just going to get a huge amount of variety in terms of, hey, I like the taste of it and I want to take it on a regular basis because I think it might help me because it's got flavonoids and other chloroquines and whatever. And I'm not worried about that. I don't think the level is likely to be toxic if you're just doing that. But do I think it's likely to be protective? I wouldn't rely on it. I'm not aware of any studies where they've looked at that. It's one of those things that's interesting, anecdotal, maybe helpful, but unlikely to be harmful, but I wouldn't necessarily rely on it. It's like the whole conversation people ask me about, what about nebulizing hydrogen peroxide? There was like one study that showed some marginally useful things that they did, and it was a small study of 25 people. And would I rely on that and start recommending it to my patients? No. But if you use a low enough dose, is it likely to be harmful? Also, no. You just have to, use your own best judgment.
Thank you.
Go ahead, Maddie.
We'll move on with intentionality. The last two questions, just a minute each, and then we'll move on. How do you differentiate between a bad cold and COVID? Is the over-the-counter testing accurate?
That's a great question. Short answer is no. The over the counter testing is not accurate. We see a lot of false negatives. Sometimes people will test negative for 2 or 3 times before they finally test positive. We're seeing that more with the current variant. And I do want to talk a little bit about the current variant, but I'll just say that I tell people to test once. And then if they still have symptoms, they're getting worse, test again, or they're not getting better, test again, and a day later. And then if they're still not getting better, test again, even if they're negative. Because I absolutely think that these tests are not great. And sometimes you're going to test positive on day one of symptoms, and sometimes you won't. But throughout this process, should you be taking ivermectin? Should you be taking vitamin C, vitamin D, quercetin, zinc, melatonin? Absolutely. Curcumin? Absolutely. NAC, if you have symptoms of any kind of congestion? Absolutely. If you have sore throat, bromelain? Absolutely. Don't wait to start these medications. Now, I will say I don't usually use hydroxychloroquine or calcitriol or fluvoxamine if I don't have a confirmed positive test, right? But will I use everything else? Absolutely. And here's the other thing I'll say is that if you've seen a lot of COVID cases, you know COVID. So that's why it's good to have the COVID prep package, because then you get seen and then we can say, okay, are you testing in the correct way, in the proper frequency? With those tests, I mean, it really helps to get up in there, and you're supposed to have it up in there for 15 seconds and you're going around. It's so funny because I had to test Maddie recently. She tested negative, but she was having some symptoms last week and she said, I don't want to do the test on myself. Could you please do it for me? And I said, okay, if you really want me to. And then she said, please don't hurt me. And I'm like, this is a test which inherently hurts. And don't ask me to do something that's literally impossible. And it sucks because you do it and you inherently are going to cry. If you're doing it right, you will cry. That means you've done the test correctly. If you're doing it and you're like, oh, that tickled, like you probably didn't do the test right. So that's the other thing, is there is the user error component to it. You're just like, oh, I'm going to go up there and tickle my nose. No, that's not correct. You got to go in there and go up high enough and really scrape it around for 15 seconds. And then again on the other side for another 15 seconds and twist it around. And I like to go up and then back because sometimes back is more accurate. That's the doctor way of doing a COVID test. I'm really thorough. And unfortunately, my wife is the victim of that. But at least I felt confident of the result and she got better within a day after that. But I think realistically, if somebody's not getting better despite suspected COVID, then I would go ahead and add in at least the HCQ and the calcitriol just to see if that's going to help. Because a lot of times it can. I had a colleague recently who said that he didn't test positive until the fourth test. I said, you tested 4 times? I wouldn't have tested 4 times. But what he found was that he had started ivermectin. And then when he started on the hydroxychloroquine was that when he really noticed a significant improvement was after adding in the rest of the protocol. And so that's another way to test. If you're on ivermectin, you're testing negative, you test negative again, you could try hydroxychloroquine and fluvoxamine and calcitriol, adding in everything else for a day and seeing, okay, do I feel significantly better? And if the answer is yes, then well, maybe do that for another few days and then you're good. And whether or not you have a positive test or not is less important now because 2 things, as Dr. Merrick likes to say, COVID is a clinical diagnosis. Number 2, I would say these tests are showing that they're increasingly unreliable with the new variants. So I wish it were not the case. I'm all about test, don't guess. That's one of my mottos. I love tests and I don't like to treat without a positive test. It's really anathema to me in a way. I hate it. But it's also a situation where the medications we're using are so safe, and B, they make such a difference if you use them early that I'd rather you use them and you didn't need them than not use them and end up with long COVID.
Okay, thank you. Last question. Is a heart valve replacement considered an organ transplant regarding potential downside to regular ivermectin use?
No. So when I talk about organ transplant, I am specifically talking about certain medications that people will be on as a result of having had the organ transplant that are contraindicated to be combined with ivermectin. So this is from the COVID Bible by Dr. Merrick, the Guide to the Management of COVID-19. And so here we have the four medications which you cannot take with ivermectin. So that's erdafitinib, lasmitinib, miditan, quinidine, tepotinib. I don't know how to pronounce these because I've literally never prescribed them. Not super common medications, but if you happen to be on these immunosuppressives, usually again due to an organ transplant, then I would say you can't take ivermectin. Most of these in the green, we can still prescribe ivermectin. We may need to adjust the dose of the medication you're taking because it could decrease the clearance of that medication. So if I have a patient, for example, that's on the maximum possible dose of atorvastatin, I may tell them cut your dose in half on days that you're taking ivermectin so that you don't end up with statin side effects, statin toxicity side effects. Yeah.
Okay, thank you. There's
Sure.
an acknowledgement that came through from Pam. I'd like to read it because I think it's important to receive acknowledgements in full, for all of us too. So Pam said that I can't say enough about how wonderful Madi and Dr. Partovi continue to be. Dr. Partovi spent almost 2 hours with my husband when he was so sick with Delta 2 years ago. I wished I had found them sooner than 5 days into his illness. Dr. Partovi asked every question in the book to diagnose and treat my husband correctly. Saved him from overdosing on aspirin too. Called pharmacists about the prescriptions he wrote. One pharmacist tried to deny all of the meds he prescribed, including ivermectin, which she never did release to us. And that's still happening to this day. And followed up repeatedly to make sure he was recovering properly. The treatment protocol worked. And when I got Omicron, the treatment and continued follow-up was just as amazing. Highly recommend. Pam, thank you so much for that acknowledgement. It's fully received by us. I know we're at 1:00, so if anybody needs to leave, I acknowledge that. And I'd like to honor what Robert F. Kennedy Jr. requested for this day, which is...
I understand, Brenda. And just by the way, recording will be available. We will send it out to those who are not able to stick around for a little bit longer.
Yeah, so I would like to honor his request for a moment of silence, and I'd like to do it a little bit creatively. I've had requests to be in silence, and in my head, I would be, how am I supposed to feel? What am I supposed to think? Am I supposed to pray? What am I supposed to do? So I'm going to lead you in a very brief introspection at Kennedy's request. So I invite you to just take a deep breath. This has been a lot to intake. So take a deep breath in. And as you begin to exhale, feel free to close your eyes for a moment. And begin to soften your facial features, your eyes and your cheeks, your jaw, your throat space. Allow each breath to massage your facial features and to relax them. Drop your shoulders. Soften the front side of your body. Relax your belly. And search for anywhere where you might be holding any residual tension. And the next time that you exhale, let that go. Take a moment to notice what's going on interiorly, with any thoughts and feelings. And relax your belly again. And thank those thoughts and feelings for being there. Then exhale, drop a little deeper into a space of interior peace. This place of deep peace and ease within your body. Your body is so wise. And notice your breath. I am breathing in. I am breathing out. And in this moment of peace and ease, acknowledge yourself for doing the inner work that has you be so curious and so enlivened and engaged out in the world with people. The moment to acknowledge that about yourself. Relax your belly, relax your jaw. And feel free to send out any intention that you have for yourself, for your family, for your community, for society, for the planet. Any intention for what happened on this day. Take a deep breath in and out, and feel free in the next few moments, just nice and easy, to come back to the space and to slowly and gently blink your eyes open. Thank you for being open to that, everyone. Dr. Ryan, for the next 5 minutes, I'd love for you to share what it is you see in this current COVID landscape.
There's just a few things that I wanted to update you guys on. The last year's COVID State of the Union, most of that stuff is still really, really useful and valuable information. And for anyone who missed it and still hasn't seen the recording, I highly recommend to give it. It's long, so when you have a chance, give it a listen. I'll put the link in the chat in case anybody has missed that. With regard to just a few things, which after that wonderful reset almost seem insignificant, but let's go ahead and share them anyway. So I just wanted to talk about specifically variants. As we can see, the rates of XBB 1.5 are going away. This is what's been our dominant strain throughout the summer, throughout the spring, really. And we had a little bit of our typical summer surge, which we see, and it was with XBB 1.5. That's what we've been treating. But we can see now that rates of XBB 1.5 are pretty much down around 3%, right in time for them to release the XBB booster. Now that nobody needs it, they're coming out with a vaccine for it. And so that's why we don't recommend that one, amongst other reasons. But we are seeing EG.5, the top variant right now. And so these are a little bit of descendants, and this is directly from CDC. And you can see how these are essentially offshoots of variants that we've seen before. They're variants that represent mutations from, in the case of EG.5, it's an offshoot of XBB 1.9.2, which never really took off. But now we're seeing its daughter, so to speak, or son, whatever you prefer, is now, in fact, the top variant that we're seeing. FL 1.5.1, so that came off of XBB 1.9.1. So these are variants of XBB, which was the original variant from Singapore that did increase a lot of hospitalizations and deaths in Singapore around last year. And then it came to the United States during the spring. And so we really missed the majority of it. And then now we're seeing the sons and daughters of XBB, a particular variant of XBB and sort of its offshoots. I did want to take a look at in the open forum for infectious disease. This is the effectiveness of the bivalent vaccine. And what was interesting about it is that the risk of COVID increased with the number of vaccine doses previously received. So you actually were more likely to get COVID the more doses of the vaccine you got in this study, which was done at the Cleveland Clinic. You guys may have heard about this study, but to me, this gives you the sort of data from the study. And then we see here, I think this is the one. This goes to show you that there is some protection if you've had an infection more recently. If you've had one of the more recent variants, you're less likely to get COVID. We see this was looking at during the BA4, BA5 time, which was last year. We saw that if you had an Omicron infection, you were the least likely to get it. If you were last infected during pre-Omicron, you were more likely to get it, and never infected, obviously, was the highest risk of all these. BQ, which kind of came a little bit after that, and then XBB has been the more recent ones. And we see that, again, if you've had a previous Omicron infection, just a lower risk of getting it, but not a zero risk, right? And then I also wanted to show you guys this slide, which I've referenced a few times. This is the one that shows cumulative incidence of COVID-19, and then over time, and basically seeing that 0 doses of the vaccine, we saw the lowest incidence, the fewest cases, 1 dose, definitely more with even a couple of doses. But then as we see, it continues to go up with additional doses. So that's another reason why we say don't get vaccinated, because if you do, you're likely to just keep moving this curve up. We do see some increased incidence of people who had the 1 dose or the 2 doses, but I suspect that over time, we're going to see that even out. I suspect if we look over the course of years, if we look, say, for example, 20 years out, I would be surprised if we still saw a significant difference. But right now, we still see a significant difference between the initial shots and totally unvaccinated. And this is just another one showing very little difference between bivalent versus not bivalent. They show like this modest reduction for people who had the bivalent vaccine. I don't really know whether that makes much sense if you take it in context of this graph back here, where the more doses, the more likely you were to get it. Anyway, I think that was all I wanted to talk about from this study. I like the pictures because then it visually represents it for you guys. So I appreciate that. This is the study I was referencing, looking at acute and post-acute sequelae, which just means consequences associated with SARS-CoV-2 reinfection. And this is the study that shows comparable or compared to no contribute additional risks of death. So basically, reinfection, they characterize that as 2 or more infections versus non-infected controls. So again, this is looking at hazard ratio, which is relative risk. It's not absolute risk. So it sounds scarier than it actually is. I just want to go ahead and say that up front. Twice as likely they found to die when you get reinfected, 3 times more likely to be hospitalized. Other consequences, they also found increased risk, regardless of vaccination status. Most pronounced in the acute phase, but persisted at the post-acute phase at 6 months, right? So they're finding that the more times you get COVID, the more likely you are to get long COVID, which I mentioned that earlier. And they're basically just saying, look, if we can reduce people getting COVID, then that's going to reduce disease burden. So let's look at some of these pictures. So you see here the scale is 1 excess burden per 1,000, 3, 10, 30, 100. So here at 100, we're looking at 1/10, right? So we see we're looking at absolute like a 10% increase at 100 per 1,000. That's 10%, right? So pulmonary consequences, about a 10% excess burden. Neurological, a little bit below that. Musculoskeletal, closer to more like 30. So that's going to be like a 3%. Mental health, right there, just right above a 10%. Most of these are right around a 10%. except the diabetes, that one was closer to 10% or 1% rather. Cardiovascular is just under 10%. At least one, though, at least something, they found 1 in 4 people in this particular study, which is, I would say it's a conservative study. But that's why I like it, because it just shows you, hey, even if you're being conservative, there's still some stuff going on. This is looking at infection, reinfection versus no reinfection by vaccination status. And really what you see here is no vaccination, 1 vaccination, 2 or more vaccinations really doesn't matter. So all this media coverage, you're going to say, oh, if you have 2 or more vaccinations, you're decreasing your risk of long COVID, you're decreasing your risk of severe disease, long-term consequences, all BS, right? That's not true. Your risk of getting long-term consequences from reinfection is just as high if you've been fully vaccinated or boosted, if not potentially greater, because you're actually more likely to get infected, which is what the previous study showed. And I just want to say, for those who are like, oh, we should have done this first. Yes, but we had that technical glitch. I'm just reminding you, that's why we're doing this at the end, because the original plan was to do this at the beginning. And then here we have this risk and burden of all-cause mortality, hospitalization, at least 1 consequence, looking at infection versus no reinfection. We see that, yes, the rate does go down over time, but the rate of at least 1 consequence stays pretty high. Even at the 6-month mark, you still see about a 4% in this study that's excess beyond what you see from the first infection. Remember, this is all relative to the first, just 1 infection versus multiple infections. I don't necessarily need to get into all this, because a lot of it's like organ specific information and people are interested in it. They can obviously go and look at the study. But to me, what's interesting from my perspective is just that there is, in fact, this cumulative risk, regardless of vaccine status, of the more times you get COVID, the more likely you are to have consequences from it. And so that's why it's important to get treated early, so that you have a very short infection. Shorter infection means less viral replication, which means less virus, which means less spike protein, which means less cytotoxicity, which means fewer long-term consequences. Obviously, certainly the best protection is just not to get it, but I find that's harder to do because it's endemic at this point. It's been endemic. That's pretty much it. I probably was more than 5 minutes there. Sorry. But I think that's good for now. It's just, I wanted to give you guys a little bit of the lay of the land in terms of the questions that I get most often and some of the research that's been done looking at that.
Thank you, Dr. Ryan. All right, just a couple of announcements. Dr. Ryan mentioned that we will be raising our prices, and this will happen at the end of September, so September 30th. And before we do that, we're offering our community a powerful opportunity. The first of which has to do with our wellness plan. So our wellness plan is an annual plan, and the initial investment for the comprehensive lab draw and the lab review is $595. We're offering $100 off of that initial investment, and the plan is $99 per month afterwards. It's one of our most powerful plans. It's been created, and that offers what conventional medicine cannot within their current structure, and what conventional medicine cannot, with the view that it sees through, with the lens that it sees through. This is for people dealing with any nagging symptoms or anything chronic, or you haven't had any answers from anybody, from conventional doctors. We would be honored to take you on as a patient. So this promotion will last until the end of September, and look forward to a follow-up email that will give you the details of this, okay? We offer preventive membership. I love what Dahlia calls it, the Ivermectin Club. It's month to month, $30. And what it offers people is unlimited Ivermectin prescriptions and unlimited access to Dr. Ryan on group education sessions, which is powerful because you can hop on, you can ask any questions, because the COVID landscape is ever changing. So that's $30 a month. And we're offering the first 3 months free for anybody that would like to register for that by September 30th. And also what's there for me to mention is, Grace, you had asked that question about the children. and the environmental toxin burden. I'm going to circle back. So Dr. Ryan and we chose to champion the fertility industry because if you do take a look at what's affecting children and all of us, it's also fertility rates are dramatically declining. So if you know anybody that has had multiple rounds of IVF, has tried for more than a year, and has PCOS or any gamut of health and wellness issues, we are there to champion that because we love helping people have babies. We love babies. Okay, does anybody have any questions about that? So look forward to the email that you'll be getting in the next couple days that will speak to those offerings. And if you have any questions at all, Anna is also there. She's great. She'll field your questions. We have links to tell you what is offered in those plans and all the details. But if you have any questions, does anybody have any now? Yes, no, you can go ahead and just unmute yourself. Go ahead and unmute yourself. Dr. Ryan.
My question is, what all is part of that wellness plan that you mentioned?
Oh gosh, okay, so much. It's a comprehensive lab draw. Like I said, it includes 40 panels, 100 plus tests. And
before you get into it, do we have this written down anywhere?
We do. It'll all be in the link that will be going out in the email. I don't need to speak to those details. All I need to say is that, oh gosh, it's a real opportunity to take a deep dive into your lifestyle, into your genetics, into really who you are as a unique individual. There is only one you. And my husband has told me, look at the differences between our facial features right now. You take a jump into your genetics, it is 10 times that. And you will have revealed to you a whole new world of health and wellness. And you will have our support with those 1,000 actions. That will start very slowly, but we've been able to accomplish so much through this basic health and wellness plan. We've uncovered what conventional medicine cannot, like autoimmune diseases. That's wild. And cancer markers. It's just wild that conventional medicine would just, it's okay. I'll see you for 5 to 15 minutes. We are here to upend that. Right. Oh, Debbie, where are you? Debbie, can I unmute you?
Absolutely.
Thank you, Debbie.
I was just trying to write you a little note that I'm 5 months into this wellness program and it's changed my life. It's awesome.
Thank you so much, Debbie, for that acknowledgement. You're just so extraordinary because the way that you've taken it on and committed to being all in and to being curiously engaged and just asking questions and taking it on, it's just really extraordinary. And I love to see the progress that you've made in just 5 months.
5 months. It's awesome. It's amazing. Everybody's like, you just glow now. I mean, it's gone all the way, not just from the diet and that, but it's also gone on to the whole factor of learning yoga and just learning all new ways of dealing with things in life. And it's just been amazing.
Thank you so much, Debbie. I know I saw you on Zoom the other day and I just told my husband, Debbie, she just glows. She's just luminous. She looks amazing.
That's awesome. It brings tears to my eyes.
Thank you, Debbie, for that unexpected acknowledgement. So beautiful. Thank you. I appreciate you so much.
I appreciate you guys.
Grace.
I want to say something. I think it was September of 2020. My friends were really sick in New Jersey. And I emailed or texted Maddie. And literally my friends say that you and Dr. Partovi saved their life. Her friend ended up in the hospital. And if it wasn't for you guys telling me to tell them to go, I think he probably would have passed. And I thank you too, because you saved my friend Jackie just by your couple little tricks that she did to help her with her blood pressure. And it was just so beautiful. So I just wanted to say thank you so much.
Thank you so much, Grace. Thank you. Does anybody have anything else to say to be absolutely complete? I would love to thank you deeply for your generous listening and your engagement. And I just feel it too, Grace. Really your love. Yeah, I feel that. We have such an extraordinary community. We really do. And you can count on us to be here in solidarity with you in this uncertainty, in this time of uncertainty. And you can count on us to champion health and wellness in a way that honors you and your unique individuality. So thank you so much for being here. And this is recorded and it will be sent out. Please feel free to share it with your friends and family and your community. Thank you so much. I can hear my little one. He's 22 months now. I know that many of you are aware that I was very big and pregnant during that very harrowing year. But I'm going to go to my son. I appreciate you. I love you. I love you, husband. And feel free. Yes. Our next event will be to address fertility questions. So look for that as well. And we're excited to be game changers in that industry.
Yeah. And if there's anybody that you know who may be dealing with fertility concerns, even if you're not, feel free to send them the information that will come through the newsletter. Thanks for being here, everyone. And I appreciate being here, especially today on a Monday, September 11th, and joining us for this. It's always my pleasure, and I look forward to seeing you all again, hopefully not too long.
Bye now. Thank you, everyone.